All right, so here's our objective today. We're going to go through some basic mechanical ventilation stuff. We're going to go through some concepts for oxygenation and ventilation, and then we'll walk through some of the sort of next steps. This is very much a ventilator 101 class. There is a ventilator 202 and a ventilator 303 class. There are definitely escalating levels of sort of knowledge and understanding for the ventilator as we go beyond this, but this is going to get you through the bulk of what you need to know basically from the ventilator standpoint. We're going to talk about this in very basic terms, and my goal here is to help you understand how the different dials essentially interact with each other. We change one, how it affects the other, and sort of how we pick a starting point for mechanical ventilation. All right, mechanical ventilation is very much a game of not necessarily trial and error or a guessing game, but it is very much a game of let's start here and see what we get from our patient and then adjust from there. All right, it's not a sort of one size fits all, or I can't look at anybody in this room and say, I'm going to put you on this and that's going to be perfect for you. All right, we're looking at what we're getting back from our patient, both from the ventilator and on the monitor. Okay, so for our sole nurse in the room, and I'm a nurse as well, what ventilator education did you get during nursing school? Yeah, right? There's the oxygen enrichment button, there's the silence button, anything else call respiratory therapy, and really during nursing school you get nothing, and then when you get into the unit or the ED there's the oxygen enrichment button if you want to take them to 100% oxygen, and there's the silence button, right? For the medics in the room, what education did you guys get on mechanical ventilation? Nothing, right? Okay. Most of the time when I talk to people, when we've taught this class probably 50, 60 times now, most of the medics respond with either nothing, or they worked for a private ambulance service where somebody handed them an LTV and said, go do vent transports, copy settings, and like go forth and like conquer. Like here's how you put the circuit on. And that's literally all the education they'll get, right? So my reason for saying that is when you get into critical care transport and sort of across the board, the medics don't know what they're doing with the ventilator, the nurses don't know what they're doing with the ventilator. It is a unique skill that most of the time we're not taught before you join a critical care transport team. Or for you guys, I think Howard County might be thinking about getting ventilators down the line for some of your further out like stations and stuff, so that you can put somebody on the ventilator and not bag them. A BVM may be the most dangerous piece of equipment that we have at our disposal because we have no idea how much volume we're giving, how much pressure we're giving, whether we're hooked to oxygen, those type of things. A ventilator, there's smaller versions. You're probably not going to get something like this. What you guys have sitting in front of you is probably the Cadillac of mechanical ventilation. The red one's a T1 and the blue ones are C1s, just an in-house version of the T1, okay? All right. Then the big thing is there's a difference between placing somebody on mechanical ventilation and actually managing somebody on mechanical ventilation. All of these ventilators in front of you, the LTV, even some of the super basic ventilators, and if you guys are interested during a break or whatever, I can go back to my office and get one of the new vents that we have. There's a footprint about this big, and it's designed more for disaster and 911 and stuff like that. But they all will start you with a set of settings, right? We turn this on, it starts with this set of settings, right? All of you guys probably have some settings in front of you, probably 12, roughly 500, a 1 second eye time. I think we turned them all down to 21% so they wouldn't alarm. But they all start with a basic set of settings. You can put most of your patients on those settings and they're not gonna die. They're not gonna get any better, but they're not gonna die, right? It's gonna continue to blow air. What the goal today is to help you understand how we manipulate the ventilator to improve the patient, and how we understand what the pathophysiology that's going on and what we need to do for individual patients to optimize them on the ventilator. All right, so you get dispatched for a 58-year-old male, complaint of respiratory distress, going ED to ED. So going from Howard County's ED back to here or over to University, 140 kilos, all right? And you walk in and this is what you see. Little short troll looking dude just working to breathe, okay? Let's say he's in an ED somewhere, he's like at Howard County's ED, just keeps ripping off the non-rebreather or simple mask. What's our next step for this guy? CPAP, right? So CPAP is a version of something called non-invasive positive pressure ventilation, right? You guys use CPAP 911, pre-hospitally, because it's one pressure and it's pneumatically driven, and we'll talk about that in a second. Most of the time in hospital, or for on the critical care transport teams, we use what's called BiPAP, which is essentially CPAP plus an additional pressure. Okay, and we'll talk through that in a second. But you're 100% right, that non-invasive positive pressure. So some sort of positive pressure with a mask. All right, so what is non-invasive positive pressure? What is CPAP?
It keeps the alveoli open.
Okay.
In the patient's lungs and helps them take. It's not giving them breaths, but it's more like assisting them when they take them.
To some extent, you're right. You're 100% right. So it's a single pressure. So do you know what CPAP stands for? Continuous positive airway pressure, right? So it's a continuous pressure, right? And bunches of people wear CPAP at night for obstructive sleep apnea, and all that does is it creates pressure and it holds that pressure. So whether the patient's inhaling or exhaling, they're getting a push of pressure on their airway and alveoli, right? And what that's going to do is it's going to help push gas across the alveolar membrane. Okay? The other name for CPAP is just PEEP. Okay, you'll see it labeled on these ventilators as PEEP. It's the same pressure. It's the pressure that we keep constant over the entire course of the breath. Okay, and then there's BiPAP. What's the difference between CPAP and BiPAP? Two pressures. So when does that second pressure kick in? When they exhale? Should be during inhalation. So it should be triggered by inhalation. And that's going to depend on it should always be triggered on inhalation. It may get false triggered depending on the sensitivity on the ventilator, those type of things, but it's always on inhalation. How many of you guys wore an SCBA in this room? Okay. What happens when you take a breath with an SCBA on? That valve has to kick over, right? So it's not like there's constant flow blowing at you, at least on the SCBAs that I've worn. You don't have constant flow. There's a valve that you have to essentially trigger. That's BiPAP. So it's a constant, you're there, and then when you trigger a breath, a valve in the ventilator kicks over and it gives you an additional pressure. Okay? So it brings that pressure up. What CPAP does is it helps you oxygenate. What pressure support, or what CPAP plus pressure support is equal to BiPAP, is what we call that. What that does is it helps you ventilate. It helps you take a bigger breath. It helps with tidal volume. Okay? Everybody tracking on this? Okay. So how can we help this work? One of the first things we can do to help this work is coaching. This is something that I desperately didn't want to learn in nursing school, but it was something that I was forced to learn in nursing school, is therapeutic communication, right? You go in and you tell the patient what's coming, and you warn them and you coach them through it. Okay, this is going to feel uncomfortable. Bear with me while this works. It's going to hopefully make you feel better. Give me 10, 15 minutes. Let's see if this can work. And the reason we have to coach them through it is because this is what it feels like to be on non-invasive, right? Feels like sticking your head out the window at 40 miles an hour, and it's uncomfortable. How many of you guys have seen people fail non-invasive, right? You try non-invasive and they're just so uncomfortable with it, they're yanking it off, they're just super, super uncomfortable. That may be because they don't know what's coming and they're not willing to sort of deal with it. We haven't coached them through it. Additionally, it can come down to some settings on the ventilator, and we're going to talk through this. For you guys with your pneumatically driven CPAP that you have like on the truck, you don't have a whole lot of manipulation. But with the ventilator, if you guys were to get a ventilator, it would come down to there's some manipulation we can do on how we deliver that gas. We can change how quick or how slow, when it gets delivered, when they exhale, those type of things. And we'll talk through that on the ventilator here in just a second. So we've done our coaching, and then we can do some tweaking on the ventilator. Not twerking, not helpful. I tried it one time, did not help at all. But we can do some tweaking on the ventilator. And the big tweaking thing that you can do on the ventilator is what's called rise time or ramp. It's called rise time on the LTV. It's called ramp on the T1 and a bunch of different ventilators. You're going to find a common theme as we talk about mechanical ventilation. Every ventilator manufacturer got together. Maybe they didn't get together. Maybe they just all stayed separate. But they all decided they're going to name their shit whatever the hell they feel like. The same thing on one vent is labeled something completely different on another vent, which makes it much more difficult to kind of talk about it from a global standpoint. But we're going to try. Rise time or ramp is how fast that valve kicks over. Go back to my SCBA example. It's how fast when the patient asks for a breath that they get their breath. So it's fine tuning of the sort of the trigger. It's a little bit different than sensitivity. Sensitivity is how easy it is for them to pull a breath. The rise time or ramp is how quickly they go from 0 to full pressure. So it's the front end of that breath. And we'll look at it on the ventilator. You guys are actually hopefully going to be able to feel this. Some people can't feel the difference in the ramp, but we're going to put all of you guys on the ventilator over the course of this workshop. Okay? So this is off the LTV, and they do it in profiles. So there's rise time profile 1, which is as fast as it'll go, and 9, which is as slow as it'll go. 1 is front loaded. So you can see 0 pressure to, let's say that's 20 centimeters of water pressure, very, very quickly. So it's up very, very fast, right? So that's our fastest profile. It's typically a profile of around 25 to 50 milliseconds. All right, and that's how the T1 defines it, is in milliseconds, an actual time. And then you have rise profile 9, which you can see, I trigger my breath, and we get a slow rise. So it's much slower on the front end. I think that, if I remember right, that equates to a ramp time of about 700 milliseconds. So pretty slow, right? Over half a second from start of the breath to full pressure, okay? Who or what profile do you think these non-invasive patients want? Go back to our example of the 140 kilo troll looking dude that's working to breathe. Does he want profile 1 or does he want profile 9? What's up? 9? Why? Okay. Anybody disagree with him? Okay. What factors make it patient dependent, or what have you seen?
So sometimes when you put the patient on something like BiPAP or non-invasive pulse pressure, they feel like they're not getting enough air with profile 1 where it's sort of linear fast.
Sure.
Versus where they put it on and slow that pressure to that profile 9. They generally lose that sensation.
Sure. Doesn't feel like they're getting the gas rammed down their throat as hard. So I would agree with you, but I will say reflexively and most commonly, these patients, these non-invasive patients, want their gas as fast as possible, right? They're air hungry. So the other thing to keep in mind is if we took them off a hospital BiPAP machine, right? This is the reason you always have to change your mask out to your mask most of the time. That's the reason almost every team will say you can't use the mask from the outlying facility because they're what's called a vented mask. A Panasonic V60 is probably the most common BiPAP machine, purpose-built BiPAP machine out there. It's designed to leak at somewhere between 100 and 150 liters a minute. So the BiPAP mask actually has a bunch of holes in it, and they've got this massive amount of gas going past their face that they can pull from anytime they want. So they never feel the valve. So when we take them off of that and we put them on our closed system where they have little to no flow when they're not inhaling, they feel that difference in those two. So they tend to want their gas as fast as possible. Personally, I reflexively turn my ramp all the way down as far as I can. I turn them to 1 on the LTV, or I turn them to a ramp of 0 on the T1. And I've had very, very few patients say that it was too fast. Make sense? All right, so this is what it looks like on the T1, and we'll go over this in a second, but it's under our more settings, and it's called P-ramp. The other thing that can help tremendously is mask seal. So despite what I want to believe deeply down in my soul, ratchet strapping the mask to the patient's face does not help. The vast majority of the time, the masks are actually designed to fit somewhat loosely. They're almost like a hovercraft. They've got like a double skirted seal on them that's designed to inflate into the patient's face. So if you strap it down real tight, all you've done is restrict that movement of it sort of molding or conforming to the patient's face. So sometimes loosening it up, despite what I deeply want to believe is not the right answer, will actually make for a better seal. Okay? All right. What's the last thing we can do to help them succeed on non-invasive? Medicate with what?
Some sort of anxiolytic, Prestex also works.
Okay. What else? What's something they have in their bag on a 911 truck that we could potentially use? Ketamine. So ketamine, great medication. Precedex, awesome medication in the hospital. Problem is, it's hard to get in the facility. I don't love Precedex in our environment because it's not sedation, it's sleep. I reflexively take Precedex off most of my sedated patients. What's another medication you guys think you have that's not ketamine? What's another medication that might help your patient succeed with non-invasive? Riptide, benzo. What's the problem with the benzo? Exactly, so knock out your respiratory. There's a reason Precedex and ketamine are probably better options because they're going to preserve respiratory drive. And ketamine even has the benefit of, in theory and in reality, causing bronchodilation and an increased respiratory rate. So if you give somebody ketamine, you can expect them to breathe faster and more often. Okay? So we got our chemicals. All right, so our guy fails intubation. So now we have to pick what ventilator settings to put him on. So now our guy's intubated, right? And every ventilator on the face of the planet has these 7 basic settings. Fun fact, they're not necessarily going to call them these settings, but you're going to get to pick these 7 basic settings. So every ventilator on the face of the planet, you're going to get to pick tidal volume, whether that be an actual tidal volume you're setting or an exhaled tidal volume as a result of a pressure, a rate, AC versus SIMV, pressure or volume, which is how we deliver the gas, I time, so our inspiratory time, our FiO2, and our PEEP. And we're going to go through each one of these and sort of talk through them and how they all kind of mesh together to give you an entire ventilator package. Okay? So, but first we have to figure out what's wrong with our patient. We basically classify our patients into 2 different groups: our lung protective patients and our obstructive lung patients. Who are our lung protective patients? What pathology falls under our lung protective strategy? Okay, altered mental status. CHF. So it's somewhat of a trick question because it's everybody who's not obstructive. So we use the lung protective strategy on everybody who's not obstructive. Who are our obstructive lung strategy patients? Who are our obstructive lung pathology patients? Asthma and COPD. Those are essentially the bookends of that group. And there's a bunch of shit in the middle, but essentially on one end, you've got asthma, which is purely what kind of disease? Where's the issue? Where's our major malfunction on an asthma patient? Airway. So it's an airway issue. Where's our major malfunction on a COPD emphysema patient? Their lungs, right? Their lung parenchyma, right? So the asthma patient is breathing through a swizzle stick, right? They're breathing through a coffee stir. They're all swollen down. They have an airway problem. Typically the lungs that are on the other end of that airway are usually just fine, right? Versus the COPDer, they've smoked all the elasticity out of their lungs, right? So their lungs have the elasticity of this bag, right? So we put air in and it stays in there. We put air in there, it stays in there. We put air in and it stays in there. This is the reason they have those big barrel chests and they're hyperinflated, right? So we're going to treat them very similarly, but there's a little bit of difference. And when we get to obstructive, we'll talk about sort of where that difference lies, okay? So the next thing we have to figure out is ideal body weight. And we always use ideal body weight for our mechanical ventilation because of this, right? As you get heavier and heavier, your lungs don't get any bigger. Your lungs are based on your height, right? I weigh about 40 pounds more than I did in high school, and I'm the same height, so my lungs haven't gotten any bigger, right? So we're going to use the ideal body weight calculation, right? That's the ideal body weight calculation. I don't fucking like math, so we all carry around more computing power in our pockets than they had all the NASA mission or all the Apollo missions combined. So get an app, right? Fun fact: all of these T1s in front of you, you can program ideal body weight on that very first screen. It gives you that height. You program the height, it will give you ideal body weight. Okay, that's how important it was. That the Hamilton people said, we're going to put it on the front screen. Interesting, it will also, if none of you guys have ever been told this about the T1, as you change that, you'll notice your tidal volume will change if you're in SCMV. That's 8 cc's per kilo. Okay, it actually changes the defaults at 8 cc's per kilo, which we'll talk about that here in a second. And then this is my last thing. This was actually the stretcher that I had at a previous flight program. I got tired of standing at the bedside doing this to try and measure my patient. It fell on my ass one day and my partner stood there and laughed at me before he helped me up. as I would expect. I would have done the same thing to him. But this is the 7-Eleven door frame measurer thing, right? You walk out of 7-Eleven, that's what's on the door jamb next to you. We ordered it from Amazon, measured from the head of the stretcher down to the rail, and then stretched it down from there. Drag your patient to the head of the stretcher, you get a rough height on them, okay? Height is super important, and for all of us that are doing interfacility transport, the vast majority of the time, somebody's gotten a height on that patient, and you usually can get that information from the sending facility, right? If it's Epic, it's right there on the left, or you can ask, and it's going to be in a chart somewhere. Okay, so you're going to figure out height, and you're going to figure out what's wrong with your patient. That's our starting point. So we need those two pieces of information to then figure out what we're going to do. So we're going to talk through the lung protective piece here. Much of the lung protective information and much of the stuff that we talk about with the lung protective strategy came out of some very old studies now. I hate to admit that I remember when these studies were done. But the ARDSNet studies basically figured out that we, before about 20 years ago, were causing iatrogenic lung damage. So we were actually overventilating people and causing people to go into ARDS by how we ventilated them. So they all kind of got together, and the little blue dots are where they did the study. Both Hopkins and University were part of the ARDSNet stuff, and they figured out the big tenets they took away from it is that we needed to run higher rates and lower volumes, right? So really what they figured out is that we were overdistending people's lungs. We were giving them volumes too big. It was not unheard of 20 years ago to go to an ICU and see a volume of 800, 900, 1,000 cc's. That was not an uncommon thing. It's almost unheard of now, right? We don't typically run volumes that large now. So what they basically found was that we were overdistending people's lungs. We were overfilling their lungs and causing what's called barotrauma, and where it breaks down the lung and causes them damage to their lung. So we found that we could go with lower volumes. But if I drop your volume and I don't bring your rate up, what vital sign is going to get out of whack? What happens when you don't breathe enough? Carbon dioxide, right? Your end tidal CO2 goes up, right? So if I lower your volume, you take little tiny guppy breaths. Let's say you take 40 little tiny guppy breaths, still not as good as 10 full-size breaths, right? Because we got to clear that CO2. So we have to go with that higher rate. And what you're talking about, right? Rate and tidal volume, what do those two together make? Anybody know? Minute volume, minute ventilation. So the reason for that is we have to maintain an appropriate minute ventilation. All of you guys in this room are pulling about 60 mLs per kilo ideal body weight, okay? I'm, of course, doing more because I'm up here running my YAP, but as soon as I intubate you, it roughly doubles to 100 to 120 mLs per kilo ideal body weight. So your baseline, a patient's baseline metabolic demand is going to require 100 mLs per kilo per minute to clear their CO2 and keep them eukapnic, okay? Now that is a healthy person. That is, Scott gets tired of hearing me talk about this, comes up here, whacks me in the head, knocks me out, intubates me. Hopefully you guys will put me on this ventilator at least 100 mLs per kilo ideal body weight. So for me, I need at least 7.5 liters a minute ventilation because my ideal body weight is 75 kilos, okay? So we take our example here, right? Our 70 kilo patient needs at least 7 liters a minute. And this is somebody who has no metabolic demand. That's not who we take care of, right? We take care of sick people. So that may be 150, upwards of 200, 250 mLs per kilo ideal body weight. So they need a lot more volume. And minute ventilation is something that I think we don't pay enough attention to, and people don't realize how big of an effect it has on your hemodynamics, right? You can dump 1.5 gallons of epi or levofed as a vasopressor into somebody, and you don't fix their CO2 if they're acidotic, it's not going to do you any good because your catecholamines don't work in an acidotic environment, okay? So we're going to back plan off of this to what ventilator settings we need to use. So if I need 7 liters a minute, and I'm going to go with a 500 cc tidal volume, and we'll get into how we select that tidal volume and rate here in a second, I need at least a rate of 14. Does that make sense? We're going to try and figure out our goal minute ventilation, and then we're going to figure out our rate and tidal volume off of that. All right, minute ventilation's king. Super, super important number. So we're always going to start with a little bit higher rate, 14 to 18, and I say higher rate based on higher than what you would do normally, right? Everybody knows a normal respiratory rate's like 10 to 14. We're going to start a little on the higher side at 14 to 18, always adjusting for CO2. And then we're going to start with a tidal volume between 6 to 8 cc's per kilo ideal body weight. Okay, we're going to figure out what that ideal body weight is, and we're going to start somewhere between 6 to 8. If your patient seems like they don't have any real lung pathology going on, start on the 8 side. If they feel like they've got some lung pathology going on, some ARDS, they've got an pneumonia, something like that, start on your lower side and then move up for minute ventilation if need be. Okay? Everybody tracking on that so far? All right. And the reason we do this is because of this baby lung concept, right? The CT scan on that right is healthy lung. All of that lung is contributing to gas exchange. Problem is, the lung on the left, lung A, is atelectatic. That's your pneumonia. If I try and put the same amount of gas into lung A as I put into lung B, it's going to over-distend the areas that are actually achieving gas exchange. So then, the good section of the lung is going to start to look like that bad section of the lung. Okay? So we have to compensate for the sections of the lung that aren't contributing to gas exchange. We're going to try and recruit those using some different strategies. But in the meantime, we need to make sure we understand we can't over-distend the good lung and cause it to be bad lung. Everybody tracking there? Okay. So we're going to talk a little about the obstructive strategy. What pathologies did we say this was? Right, so our asthma and COPD patients. So our asthma patients are on one end of this spectrum, and our COPD patients are on the other end, in that we said our asthma patients have an airway problem, all right, and our COPD emphysema patient has a lung problem. We're going to treat them very similarly. What can neither one of them do well? What do both of them suck at doing? What part of breathing? Agreed, but what part of breathing? The inhalation or the exhalation? Both of them suck at exhaling, right? And when I say they suck at exhaling, they take forever to exhale. They take a very, very long time to exhale. Our asthma patient, the reason for that is essentially a ball valving action, right? I can get air in, right? Whether I'm pulling it in, if I'm spontaneously breathing, or on the ventilator, I'm pushing it in. I can push it past that edema, expand that shrunken airway, but then it's going to ball valve behind that. It's going to trap that air, okay? Our emphysema patient, their problem is they have no elasticity in their lungs. Their lungs don't spring back. So I put air in and it stays in there. And then I put air in and it stays in there. And so they exhale very, very, very slowly. So you'll see an emphysema patient, and I'm sure you guys have all seen it, doing like the pursed up breathing, right? They breathe in, and then it's like a very, very slow exhale. And we need to mimic that. The reason they're doing the pursed up breathing is they're trying to auto-peep themselves. But beyond that, they can't exhale quickly. They're having to forcibly exhale. Versus you, if I fill up your lungs, and you guys probably saw it when you were using BiPAP, your lungs are pushing that back out. You're springing back. And the reason for that is because you've got good, healthy, elastic lungs. They've smoked all the elasticity out of their lungs, and they have big, floppy, trash bag lungs. So we're going to run low rates on these patients, okay? And we're either going to run our high or low volume, and I'll talk about why that is. But the reason for the low rate is that exhalation piece, right? If I run a higher rate, I only have a finite amount of time to inhale and exhale. It's something called cycle time, and we'll talk about it here in a little bit. But it's the measure of start of breath 1 to the start of breath 2. The faster I breathe, the shorter that time gets. Which means if the patient's breathing quickly, they have less time to exhale. Okay? So we're going to run a lower rate on these patients. And then the volume is going to be dependent on what we can get to maintain a minute ventilation. So we're going to start at a breath rate of around 6 to 10 breaths per minute on these patients. Always on the low side. And then we're going to start anywhere between 4 cc's per kilo ideal body weight up to 10, 12, 13. And the reason I say that is really, really profound status asthmaticus patient, right? Really, really tight airway, normal lungs. I may only be able to get 4, 5 cc's per kilo into them, right? Because their airway is so tight. On the other hand, I've got my COPD emphysema patient who's got big, giant trash bags for lungs, right? They got these huge lungs. Let me take advantage of their huge lungs and then give them lots of time to exhale that out. So I might set them at a rate of 8 and give them 1,000 cc tidal volume. Their peak inspiratory pressure is going to be super low because they got these big giant trash bag lungs, and then I give them forever to exhale. Okay, and we're going to talk about cycle time and eye time and breath rate here in a second. Does that make sense? So we can take advantage of their big lungs to get them a minute ventilation that's appropriate by letting them exhale, giving them a nice long time to exhale. And then this is the last thing we have to talk about with our obstructive patients, this concept of permissive hypercapnia. What's a normal end tidal CO2? 35 to 45. If you try and correct somebody down to 35 to 45 who lives in the 70s, you're going to create a bunch of different problems. Number one, if they live in the 70s, they already have a baseline metabolic alkalosis. So their kidneys have kicked out a bunch of bicarb to balance that out. If you fix them down to normal, it's going to cause other problems. More importantly, you're going to have a hell of a time on a ventilator, or even just coaching them through trying to get them to breathe that fast and get that amount of CO2 off. So being okay with permissive hypercapnia and understanding that patients' bodies tend to compensate for hypercapnia better than they do hypoxia and hypotension. Does that make sense? So being okay with an elevated CO2 is something we all have to kind of get used to. I know as a 911 provider, I suffered from the disease of I want to turn the patient over with perfect vital signs. I want them to a rate of 60 and a BP of 120 over 80 and an end tidal of 35 to 45 and a sat north of 95, because I didn't want the triage nurse to go, why didn't you fix them? Right? I was that triage nurse, so I can say that. But don't get caught in that trap. Be okay with that permissive hypercapnia. All right, last thing I'm going to talk about here, and then we'll take a quick break, is analgesia and sedation, and then paralysis. For a patient that you have intubated and is on the ventilator, you need to have some level of analgesia and sedation strategy in place. Analgesia probably more important than sedation, in that if I can give you an appropriate level of analgesia, I'll need a lot less sedation. Analgesia typically does not cause hypotension. Sedation, hands down, probably the top reason of iatrogenic hypotension, right? Propofol drip will drop your blood pressure 9 times out of 10, okay? If not 10 times out of 10. Problem is, propofol will make you forget you're in pain, but you're still in pain as a patient. So we have to give analgesia. There is no analgesic properties to propofol. So analgesia first, and I'm talking 2-3 mics per kilo of fentanyl, not in one shot, but getting appropriate amount of analgesia on board, and then putting your sedation in place. Or if you find the patient on just sedation, I find people on propofol all the damn time, getting them loaded with some analgesia and then decreasing your sedation, because you're not going to have as many hemodynamic problems. And then the last thing here is paralysis. Paralysis is an extraordinarily powerful tool. A shot of rock or VEC will get you a lot of places, but, and this is a little bit of my soapbox, if you're going to paralyze somebody, you better have their analgesia and sedation right first. The amount of times that I have found patients, gone to one particular hospital in this general vicinity that believes that paralytics, well, Vecuronium in particular, is an antipyretic, anti-seizure medication, analgesia, sedative. I lost count. Awake paralysis may be the most brutal thing on the face of the planet, to have your body and diaphragm paralyzed and be fully aware of it. Seems like hell on earth to me. So if you're going to paralyze somebody, make sure your analgesia and sedation package is right first, and they're in a nice deep dark hole, and then by all means paralyze them if you need it. Most of the time we don't need to paralyze our patients if we can get the ventilator synchronized with them and get the ventilator programmed appropriately to achieve their goals. There are a handful of patients where paralysis is sort of your only option and will go a long way. We saw a ton of it during COVID. Hypoxic respiratory failure patients, notoriously, their brain fights and does shit that's not good for them because they think they're dying. Their brain is just freaking out and will make them breathe in some very, very strange ways. And if you can take them out of the equation, they'll do much, much better. So, get off my soapbox there. Questions about this? Okay. All right, y'all take a quick break. Everybody back? Let's do this thing. All right, so we sorted out tidal volume, we sorted out rate. Now we have to sort out AC versus SIMV. So, When we talk about AC versus SIMV, all we are really defining is what the ventilator will do when the patient triggers a breath. Okay? If you paralyze the patient and put them in SIMV, it will do the same thing as AC. And we'll look at that here in a second. But all I want you to think about for the next little block of instruction here is AC versus SIMV defines what the ventilator does when the patient triggers a breath. So, assist control, or AC. Anybody know what the difference between AC and SIMV is? Anybody have an understanding of this?
Just control is every breath is a controlled breath by the vent. So if the patient triggers it, it's going to go to the program in a program of action.
Yes.
SIMV is when the patient triggers breath, there's a pressure support of that breath, but it's not going to be a full program breath. The patient probably going to draw, and that's it.
To some extent, yes. Your AC, perfect. SIMV is a little bit different, and we'll talk about that here in a second. So AC, exactly like he said, whether it's machine-initiated or patient-initiated breath, it's the same breath. So if I say I want a 500 cc tidal volume breath, and I say I want to rate a 12, for 12 breath, it's going to be 500 cc's. The patient triggers a 13th, 14th, 45th breath, it's a 500 cc breath. So same breath, whether it's machine-initiated or patient-initiated. Where SIMV differs is we're going to try and work together. So SIMV stands for synchronized intermittent mechanical ventilation or mandatory ventilation, depending on the book you read. And really what that comes down to is the ventilator is going to try and work with the patient to achieve the minimum number of breaths that you've told it needs to achieve, and then it's going to support the breaths beyond that. And the breath support is essentially the BiPAP you guys were on at the beginning of this class. So it's that pressure support. When the vent feels like you triggered a breath, it's going to give an additional pressure, just like you guys felt with BiPAP. So it's essentially BiPAP plus a guaranteed rate. So we'll look at it here in a second. This is what it looks like graphically. Okay? So this is what SIMV looks like graphically. We talked about cycle time or breath period. So that's what each one of those is. So at a rate of 12, each one of those breath periods is 5 seconds. Okay? Because we take 60 seconds divided by 12 gives us 5 seconds from the start of breath 1 to the start of breath 2. Okay? So that first block there, we break that breath barrier. Right? We put our patient on the ventilator kind of off the screen over here somewhere. We put the patient on, they get a machine breath. Okay? Patient's not taking any spontaneous breaths. The ventilator is then going to wait through that entire breath period till we break that breath barrier. We're going to get another machine breath on as soon as we break that breath barrier. As soon as that triggers, we're going to get a machine breath, that black breath. Now the patient's going to trigger a breath. We're going to get that first purple breath. Okay? So each one of those breaths so far, what mode is that so far? So patient-initiated, machine-initiated breaths, all the same breath, AC. So up until that point, that's an AC mode. Okay? So whether it was machine-initiated or patient-initiated, same breath. Where it starts to change is when you get into another breath inside of that breath period. So a third breath inside that breath period is going to give you a pressure support breath. Notice how that breath is smaller. Typically that breath is going to be smaller because we're not going to give it with as much pressure. If you were to turn the pressure support up to the same pressure that was required to deliver your AC breaths, it would be the same. And we'll look at this on the ventilator here in a second to make a little more sense. So now we break that breath barrier. Notice how we did not get a machine breath as soon as we kicked over. The ventilator said, this is where that synchronization piece comes in. The ventilator says, hold on, you were trying to do some work, so I'm going to let you. So now we break that breath barrier, and we don't get a machine breath, but it waits, and the patient triggers a breath. We get that second purple breath there inside that breath barrier, and we get a full support breath. Okay? Now we trigger another breath, right? This doesn't ever work. We trigger another breath, we get a pressure support breath. We trigger another breath, we get a pressure support breath. I want you to notice how this pressure support breath sits on this breath barrier, right? It didn't magically break that barrier and hammer in a machine breath on them. So now it's going to wait again, right? We're going to wait. We're going to get a full support breath inside of this breath period. I hit them with some fentanyl, knock them down, right? Now they're not breathing on their own anymore. It's going to wait through an entire breath period because it said, you were trying to do some of the work, I'm going to let you do the work. It's going to wait through an entire breath period until we whack out them another machine breath. Okay? This mode was designed to take people off the ventilator. It's a weaning mode. The reason we teach this in this class, because we don't wean people off the ventilator, is the amount of times that we go out and pick up patients that are on long-term vents or have been on a vent for a while, they may be on SIMV, because we want the patient to do as much work as possible, because if they don't do work and we take care of everything, they'll start to atrophy, right? And then they can't breathe on their own. So we want the patient to breathe on their own as much as possible in the right circumstances, right? Not necessarily in the acute phase of their illness, like, right, I get run over by a truck, we want to take over all of it. But you got run over by a truck 6 months ago and now you're trying to get off the ventilator. I want you to do as much work as possible to work out those muscles. Questions about SIMV? Okay, all right. So now we're going to talk about pressure versus volume. And in pressure versus volume, all we're talking about is how the flow is delivered, right? So we manipulate flow. I was talking to a respiratory therapist one time. He said, all I am is a flow jockey. All I do is decide how fast the flow gets delivered, when it gets delivered, for how long it gets delivered. Most of mechanical ventilation just falls back down to controlling flow. So we're going to talk about pressure versus volume and how it really comes down to the flow. So in a pressure mode of ventilation, the ventilator cycle is based on a set pressure over a set time. Okay, that set pressure is our pressure control number, and that set time is our inspiratory time. The flow is front loaded. So in this case, the ventilator turns the flow on wide open until it hits the pressure we asked it to hit, and then it maintains flow to maintain that pressure. Okay? Our volume is variable. We have no idea how much volume that's going to create. This is the reason you can put me and my 8-year-old on the same pressure control settings, and it's going to be safe for both of us. You put me on 20 centimeters of water pressure, I'm going to get a 500 cc total volume. You put him on 20 centimeters of water pressure, he's going to get 150 cc total volume. It all depends on the container we're trying to put into, right? My lungs are bigger than his lungs, so the amount of pressure is going to differ as we fill up those balloons. Okay? This is what it looks like from a waveform standpoint. Pretty much every single ventilator on the face of the planet, your top waveform is going to be your pressure waveform. It's what it is for these T1s. And then your middle waveform is going to be your flow waveform. I want you to notice our pressure waveform, which is on top. This is a measure of the pressure in the airway. Our pressure goes up to, in this case, 15 centimeters of water pressure, holds for 1 second, which is our inspiratory time, right, TI, and then drops back down to PEEP. Our flow is front loaded. So in this case, the flow turns on at, let's call that 75 or 80 liters a minute. So flow 80 liters a minute until we hit our pressure goal, and then it does what's called decelerating off. It's a decelerated waveform, so it looks like a backside of a really steep-ass ski slope, right? So our flow tails off to maintain that pressure. And then we open our exhalation valve and we get negative flow, so flow below that flow waveform, okay? So our flow is front-loaded. We turn flow on as wide as we can until we hit our pressure, and then we shut it off, okay? So I want you to think about this as you've got a jug, right? You put it under your kitchen faucet. Say it's a gallon jug. I want to fill that up. I'm going to open my faucet wide open, okay? I don't know how long that's going to take necessarily. So I have to stand there, and when I get to the top of the jug, I shut it off, right? Doesn't shut off completely. At least my faucet doesn't. It tails off as I close it, right? So that's that slowing down, but I still want to fill up that jug. Make sense? Okay. And this will make more sense when we talk about volume. So that's how we do pressure. The flow is front loaded, so we put the flow in as fast as possible on the front end, and then it tails off. Volume, the ventilator cycle is based on the flow needed to deliver a set volume over a set time. So we told the ventilator, this is how much volume I want. The ventilator does some math and says, I need to blow this fast for this long to achieve that volume. Our flow is constant. So it turns flow on at X amount of flow needed to deliver that volume. And then our pressure is variable. Once again, you put me and my 5-year-old on the same pressure or the same volume settings. My peak inspiratory pressure is going to be 20 and his is going to be 55. Okay? Because his container is much smaller. So we're going to overpressurize his container. Everybody tracking on that? Okay. So this is what it looks like in a waveform standpoint. Back to our pressure waveform. Our pressure waveform upticks, right? Goes up Because we are inflating the balloon. So the pressure is going to grow inside of my airways, inside of my lungs, as I put more and more volume in there, more and more flow. So we get an upward trend on our pressure versus it being square. Now if we look at our flow waveform almost looks like our pressure waveform in the pressure control slide. It's square. In this case it turns on at 30 liters a minute, right? And it maintains 30 liters a minute for 1 second. The reason it does that is I told it I want 500 cc's of tidal volume. It knows that if it blows at 30 liters a minute for 1 second, it'll reach 500 cc's of tidal volume. Does that make sense? So this is how true volume ventilation works with a square constant waveform. Okay? In volume ventilation, your alarm limits serve two purposes. Your high pressure limit serves two purposes. An alarm limit to make noise and yap at you, but more importantly is a safety valve. Back to my analogy of me and my 8-year-old, right? You put me on 500 cc's of tidal volume, my peak instrument pressure is going to be 20. His is going to be 55 if we move that limit, but we set our limit at around 30, right? So it's going to hit 30, it's going to dump the exhalation valve on him. This is the reason we have to set high pressure limits appropriately, and the reason we go in and we set our alarm limits appropriately. They serve multiple purposes. All right, so now to just confuse the living shit out of you, PRVC. So PRVC is the two together. So PRVC stands for pressure regulated volume controlled. So it's a volume target with a pressure breath. Okay? So we say, I want a 500 cc tidal volume. Okay? The ventilator delivers a 500 cc tidal volume breath. It looks at the pressure needed to deliver that breath. And then the next breath is a pressure breath at that pressure that it took to deliver that volume. So in our example here, our 500 cc tidal volume breath, we get a volume breath at 500 cc tidal volume. The next breath, let's say that took 20 centimeters of water pressure. The next breath is going to be a 20 centimeter water pressure breath, front-loaded flow. Okay? It's going to look at the volume that came off of that. That was a 580 cc breath. Shit, too much. So then it's going to drop it by anywhere between 1 and 3, depending on how far off the target it is. So in this case, it's going to drop it by 2. So now this is going to be an 18 centimeter water pressure breath. Okay? That was a 500 cc tidal volume breath. Awesome, still winning. Next breath, 18 centimeter water pressure breath. 500 cc breath, cool, still winning. Next breath, 18 centimeters of water pressure. That one was only 430. Shit, not enough, gotta go back up. So back to 20 we go. So it's breath by breath adaptability of pressure based on a target volume, okay? This is what the T1 does, okay? So the T1 is incapable, T1 and the C1 cannot do a true volume breath. It does a PRVC mode. What is referred to as volume on here is actually PRVC, and then it does true pressure control, okay? Which is the reason we have the LTV. So now we're gonna talk briefly about I time, okay? I time is our inspiratory time. We don't have control over expiratory time. We only have control over inspiratory time, right? So the way we control expiratory time is by controlling rate and I time. So I time is the time that the expiratory valve is closed. I want you to think about that. It's the time that we're inhaling, right? It's the time the expiratory valve is closed. Typically, it is anywhere between twice as long to 6 times as long that we're in exhalation than we are in inhalation, okay? And the way we pick an I time is somewhat based on the patient. It's also based on our goals, okay? So, the first concept we have to understand is cycle time or breath period. We talked about this when we were talking about SINV. It's the start of breath 1 to the start of breath 2, right? The faster your rate, the smaller that time is, okay? So we'll take our really crude example here, right? My really shitty drawings. At a rate of 10, our cycle time is 6 seconds, right? 60 seconds divided by 10 gives us a 6 second cycle time, okay? If my I time is 1 second, my IDE ratio is 1 to 5. So I have 5 seconds to exhale, I have 1 second for inhalation. Now you double that rate, and we cut our cycle time in half down to 3 seconds, but we leave our I time the same, our ID ratio shrinks exponentially down to 1 to 2. Okay? So the reason I bring this up is what I want you to think, rate and I time are tied together. Okay? If you're going to change rate, you have to think, do I need to change I time? Okay? As rate goes up, I time needs to come down because you're shrinking your entire cycle time. And we need to take up less of it with inspiratory time. Okay? Now, if we take our I time and we drop it from 1 second to 0.8, we get back almost to a 1 to 3 ID ratio. Fun fact, you can set your rate to whatever the hell you feel like, and your patient still gets a vote. So whether you increase the rate to 20 or the patient increases their rate to 20, it's the same effect. Okay? The big takeaway here is as rate goes up, I time needs to come down potentially. So for me, rough ballparks, and a lot of the stuff that I talked about today, the numbers I gave you guys are starting points. But a rate less than around 20, I'm at around an I time of 1 second. Okay? Up to about 18 to 20, I'm around 1 second. From about 18 to 20 to 24, I'm around 0.8 to 0.9. Above 24, I'm 0.8 to 0.75. Above that, I'm down at 0.7. I personally don't like an I time shorter than 0.7 in an adult. It's just too fast. They can't get their gas in. We start getting that Dixie cup fire hose thing where we start bouncing back with high inspiratory pressures. Does that make sense? Everybody tracking on that? Okay. Typical ID ratios are 1 to 2 and 1 to 3 for our lung protective patients and 1 to 4 or greater for our obstructive patients. We have to have an I time of 1 to 4 or greater on our obstructive patients because we need to give them a nice long time to exhale. Like we talked about at the beginning of the presentation, their issue is exhalation, not inhalation. We can get gas in them all day. It's giving them plenty of time to exhale. Okay, auto PEEP. So auto PEEP is what we are trying to avoid by appropriately setting rate and I time. Okay? Because if we don't we don't bring our I time as our rate goes up, we don't bring our I time down as our rate goes up, we're going to start our next breath before the last breath ended. It's called auto PEEP or breath stacking. A lot of people call it breath stacking. It's breaths being stacked on top of each other, or you getting your inhalation phase before you're fully exhaled. Does that make sense? Okay, this is what it looks like on waveform. You're going to notice your expiratory flow does not come back to 0. Okay? If we look at this as a whole, right? We have a rate of 35. We have an I time of roughly 1 second. Okay? ID ratio is 1 to 1. So we have roughly an I time of 1 second. So at a rate of 35, their I time's way too long. Okay? Does that make sense? And that's where that auto PEEP's coming from. That next breath is starting before we're fully exhaled. Okay? We're trying to avoid this. At all costs, we want to avoid auto PEEP because it's going to increase interthoracic pressure. It's going to decrease hemodynamics, and it's going to cause you not to be able to clear CO2. Okay. Next on the list is FiO2. Okay. So the amount of oxygen we're giving. All of you guys are running 21% right now just because we don't have an oxygen source on here, but we typically don't run 21%. My low end is about 30%. If you're going to come for a ride with me, you're getting 30% FiO2. But it is not uncommon for us to find patients on 100% FiO2, and they will have been that way for a long period of time. We know that hyperoxia is bad for people. It's pro-inflammatory. It's also, let's be honest, we are all in an oxygen poor environment, right? We have a finite amount of oxygen. In the hospital, we have an unlimited amount of oxygen in the wall. But all of us in this room, when we're doing our job, we're running off of tanks. So I have a finite amount of oxygen, so I want to use as much of an oxygen sparing strategy as possible. Additionally, we know that hyperoxia is bad for people, right? Oxygen-free radicals, it's pro-inflammatory, all of that stuff. So my goal always, and I would hope that I can pass this on to you guys, is to aggressively down titrate FiO2. Because I have literally never seen a respiratory therapist turn FiO2 back up when I drop them off. However, if I drop them off on X amount of FiO2, they're going to stay that way for at least an hour, if not longer. So the goal, and for us as transport providers, I think this is a place that we can make a big difference, is getting people's FiO2 down. So we go out for this 38-year-old female with a subarachnoid. Right, subarachnoid, yeah. We walk in. She's on a rate of 12, a 1 second eye time, a 400 cc tidal volume, 100% FiO2, and 5 of PEEP. Okay? She's sat in 100%. A SAT of 100% is the most useless number on the face of the planet. It tells me absolutely nothing, right? It tells me your PaO2 could be anywhere between about 80 or 90 and 480 or 490. So I don't actually want a SAT of 100%. I want a SAT of 98% or 99%. So back to the ARDSNet folks, they came up with a PEEP FiO2 ladder. Basically what this is PEEP and FiO2 should move up in concert with each other, as opposed to taking one dial and turning it all the way to the right, which is what happened here. These are what I affectionately refer to as ED settings. Every ED patient, after they get intubated, gets put on these settings, okay? If it's a male, it's 500 cc's. If it's a female, it's 400 cc's. But essentially, they get put on these. RT walks away. The physicians walk away, and they never down titrate until they call us, and we need to move them. And then we can make a difference here. So they're setting 100%. I walk in. I'm going to look at this PEEP FiO2 ladder. Okay? So if they're on 5 of PEEP, they should be on 30% FiO2. If they're on 5 of PEEP, they should be on 40% FiO2. Now, this is a guide, right? But let's say we're going to do this to the letter of the law. I'm going to walk in. I'm going to put them on 30% FiO2 and leave them on 5 of PEEP. Their SATs are going to drop to 90. Well, shit. Okay? Now I need to go back up. But at least now I know where I'm at. So now I'm going to move up this ladder. 40% and 5 of PEEP. Okay? 40% and 8 of PEEP. I'm going to move up that ladder in a stepwise fashion. Okay? And I'm going to get back to 100% of FiO2. Yeah, cool. Now I know where I'm at. I at least moved my way up, and I can confirm that 100% of FiO2, I only need 40% of FiO2 for that. Now, in reality, I don't do this, okay? I don't walk down this PEEP FiO2 ladder like this. In reality, I walk in, I find them on 100% of FiO2 and 5 of PEEP. I turn them down to 60% of FiO2, okay? And then I go about my day. And if they're still satting 100%, I drop them down to 50% of FiO2 10 minutes later. And then I keep packaging them, I put them on the stretcher, I go in the ambulance, and then 10 minutes later, if they're still sat 100%, I turn them down to 40% of FiO2. And then 10 minutes later, if they're still sat 100%, I turn them down to 30% of FiO2. And then I leave them there. Does that make sense? This PEEP FiO2 ladder, the reason I show this to you is because it's very, very important to understand that PEEP and FiO2 should move up in concert with each other. Instead of just taking one dial and turning it all the way to the right, they should move up in a stepwise fashion. Plateau pressure. So you have a couple different pressures on your ventilator. You have plateau pressure, you have peak inspiratory pressure, and you have mean airway pressure. All three of those pressures serve a purpose. Plateau pressure is the pressure I care about the most in most of my patients. Plateau pressure is the pressure we see at the alveolar level. And it really only matters in volume ventilation, true volume ventilation. If you're in PRVC or a pressure control ventilation, your peak inspiratory pressure is your plateau pressure within a point or two, because we're running a pressure control. I'm saying push to this pressure, the ventilator pushes to this pressure. As long as I know that pressure is less than 30 or 35, which is our top end plateau pressure, which is where we want our plateau pressure, less than 30 to 35, I know I'm safe. So I can equate plateau pressure to peak inspiratory pressure in pressure control or PRVC. Everybody tracking on that? Okay. Plateau pressure and eye time. This is another way that I want you to think about plateau pressure and eye time, but particularly plateau pressure in relation to eye time. So in a pressure control ventilation, plateau time, eye time equals time at plateau pressure. Okay, and in volume ventilation, eye time equals time to plateau pressure. So go back to what we were talking about with pressure versus volume. Pressure is a pressure over a certain amount of time versus volume is a volume over a certain amount of time. So our top pressure is going to be at the very, very end of a volume breath versus it's going to be over the entirety of a pressure breath. Does that make sense? Okay. We're going to talk briefly about compliance. Compliance is how stretchy that lung is. So our sick ARDS patient, right, our sick pneumonia patient has very, very poorly compliant lungs. They have very stiff lungs. On the other end of the spectrum is our COPD emphysema patient, right, with the trash bag lungs. They have very, very, very compliant lungs, okay? So we're going to use a concrete example here of this Coke can. On the left, we have a fully intact Coke can, right? And I want to put 500 cc's into that Coke can. I need to push at 20 centimeters of water pressure to put my 500 cc's in there. On the right, I have that crushed Coke can. I want to put that 500 cc's in that same crushed Coke can. Smaller space, right? I have to push at 40 centimeters of water pressure to push that 500 cc's back into that Coke can. In a very, very concrete fashion, I want you to think, what can I do to that Coke can to make that 500 cc's go back in there with less pressure? PEEP, right? So how do I create PEEP on that Coke can? I pull it back out, right? I can create PEEP by recruiting that Coke can back out. If that's your alveoli, I want to recruit that alveoli. Make sense? Okay. So the way we do this is we use either a recruitment maneuver or something called PEEP of best compliance. And we're going to look at what PEEP of best compliance is here in a second. So people refer to PEEP of best compliance as a recruitment maneuver. It is not a true recruitment maneuver. A true recruitment maneuver is a large pressure or a pressure over a lengthy time. Typically it's like 30 centimeters of water pressure over 30 seconds. So it's a long inspiratory hold. Okay? If we pull the lungs back out, right? Okay? And I push 30 centimeters of water pressure and I do an inspiratory hold, we're going to blow all those alveoli open. You guys saw what I did when I recruited my lung really, really fast. That's a recruitment maneuver. We push for a pressure over a period of time to blow the lung open. Okay? There's been tons of studies. Recruitment maneuvers don't work. The reason is because we blow the lung open and then it collapses back down. The better way to do this is to recruit the lung using PEEP over an extended period of time. It's also probably a much more gentle way to recruit the lung. We're going to talk about our PEEP of best compliance study. Okay? So you're going to look at whatever your PEEP is. And on the T1, you're going to look at page 3 and you're going to look at your compliance. Okay? So you're going to note what your compliance number is. You're going to increase your PEEP by 3. Okay? So let's say you started at a PEEP of 8. You're going to turn it up to, or a PEEP of 5, you're going to turn it up to 8. Sure, yeah. Then you're going to wait 5 minutes. Okay? And after 5 minutes, you're going to note your compliance number again. If that number got bigger, then you found more lung. You recruited lung. You're going to go up by another 2 of the PEEP on PEEP. So you're going to go from 8 to 10. If that number did not get bigger, I don't really care what that number was to begin with or what that number ended with. It just has to get bigger. Okay? If it didn't, we're going to go back down to our previous PEEP level because we've fully recruited the lung. So compliance is a measure of how much pressure it takes to deliver a certain tidal volume. So if there's less pressure to deliver a certain tidal volume, my compliance is better. Okay? What we're trying to find is what's called the upper inflection point of the lung. At some point, we can't stretch the lung anymore. So we're trying to find that top inflection point of the lung because we're trying to do whole lung ventilation. We're trying to use the entire lung and not have any of that area be atelectatic. Okay? Is everybody tracking on this? Okay. I use this pretty religiously to optimize PEEP on most patients. Okay? We want to be able to optimize the patient and take the example of your first call of the day is a cachectic little old lady. She weighs 70 kilos maybe, soaking wet. And then your next patient of the day is 170 kilos and is 5'3". Okay? Do you think they need the same amount of PEEP? Okay, who needs more PEEP? What's up? The 170 kilo, why? Body habitus. What particularly about the body habitus? They get a lot of mass on their chest, right? This is the reason that you have to sit these patients up. Sitting these patients up, right? Heavy patient, heavy chest, like large woman, pendulous breasts, there's a lot of weight on her chest, right? If you can get her set up and offload some of that, and this could be a guy too, you offload some of that, that's going to go a huge way. But then the next step is going to be PEEP. That patient needs 8 or 10 of PEEP just to move their chest wall and just to put that functional residual capacity that we talked about back. Make sense? So this allows us to figure out what is optimal PEEP for each individual patient. All right. Questions on anything we talked about today? It's a lot of information. It's kind of drinking from a fire hose. The ventilator is very much something you have to put your hands on and play with and utilize to really solidify. You could sit here for 2 hours and listen to me and get a start, but you have to put your hands on it and touch it and work through patients and problems and pull out a test lung and play with it and see how it reacts. It very, very, very much comes down to knowing what your equipment is doing and how you can manipulate your equipment to achieve what you're after, right? So for you guys, understand your CPAP device, understand how we can manipulate that and improve the patient. Understand putting a PEEP valve on your BVM, right? Super, super important. Utilize the equipment you've got and understand how it works. So my big takeaways is, like I said, know your equipment. Minute ventilation is really, 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 really important, and understanding that minute ventilation is probably one of the most important aspects that you can understand about mechanical ventilation. Plateau pressure is the pressure we care about. So if you have a volume ventilation, you need to understand what that plateau pressure is. I don't really care about peak inspiratory pressure in a volume ventilation because it's dirtied up by the upper airways, by the ET tube, by whatever they might have in their ET tube. And then all we really are doing is controlling flow, right? What we control is flow, and understanding pressure versus volume and how we can utilize that to accomplish our goals is really, really important. And I say that, an example of that is if you're ventilating a CHF patient, right, that has full flash pulmonary edema, or you're ventilating a post-drowning, pressure is your friend there. They've got a bunch of crap in their lung or between their alveoli and that vascular bed, and pressure is going to help you push that gas across that alveolar membrane. On the other hand, volume and how you deliver your volume is going to matter a lot more for your asthma patient, because they can't get air in or they can't get air out, and they're having a hard time getting air in. And if you try and force that air in, all you're going to do is be bumping up against that tight airway. So going to a volume ventilation can really, really be a benefit for them. In fact, we've had a couple situations with the T1 where we haven't been able to ventilate the patient because they're that sick from a status asthmaticus standpoint that we can't give them enough pressure. We have to go back to the LTV or an ICU ventilator that will push a higher pressure and allow that to be delivered, or a volume ventilation, because the T1 and the C1s won't deliver a volume ventilation. So understanding your equipment is key.